All right, well, we'll get started. So for those who didn't get a chance to see here at the start, my name's Sahanna. I'm one of the senior physios working at Perform Physio and Pilates. So I'm trained in women's health. So I wanted to really talk to you all about just what happens during pregnancy and the types of exercise that you can engage in and what's safe and what might not be. And we've got Tracy here, who's a sports GP who works in Heidelberg near Warringal Pirate. So she's going to be joining us and putting her input in on the medical side of things. So welcome everyone. So I think the first thing I'd like to talk about, and it's probably something that you've obviously heard of, but probably don't know in a lot of detail, is the pelvic floor. So a fun stat for everyone to see is actually at the end of pregnancy, the weight of bub on the pelvic floor is actually to be found equivalent to about 100-kilo man standing on a trampoline. It's actually really significant when you think about it. And obviously the bub will grow, and towards the end of that 9 months, you're talking about 4 kilos worth of weight on your pelvic floor. So we want to make sure, especially during your pregnancy and especially afterwards, that you've got that adequate strength to your pelvic floor to make sure that you can support bub. So I guess main reason we want to talk about it, like I said, is the pelvic floor is going to support your pelvic organs. So has anyone heard of a prolapse? Feel free to unmute. Trace, do you see many cases of prolapses yourself?
Yeah, so I used to do full general practice, and now obviously I focus on sports medicine more, but I see women obviously, pre-pregnancy, during pregnancy, and after pregnancy in my work, and I think it's something that it's very common. So, and it's something that I think we're getting better at talking about as women as well. So, but very common.
Yeah, definitely. And I think the stats at the moment is 75% of women will actually have some kind of degree of pelvic prolapse in their lifetime. So essentially we'll go into it a little bit more detail, but when your pelvic floor isn't strong enough to support those organs anymore, you get a descent or a drop of those pelvic organs, and that's what we call a prolapse. And there are different degrees for that drop in the pelvic floor, so the pelvic organs, and that will determine how significant the prolapse is. And then the next, important role of the pelvic floor is for continence. So any kind of weakness in your pelvic floor can sometimes cause leakage. So there's urinary incontinence where you can get leakage of urine. It also includes even just the inability to control wind. So for example, you're not able to hold in the wind in a room full of people. And then also fecal incontinence, so the back passage. And lastly, very important role in sexual function. So if we move on, I've got a little video here just to show you exactly what the pelvic floor is. So as a physio, we're going to focus a little bit more on the musculature of the pelvic floor, but I think it's important to realize the pelvic floor is actually a complex sort of web of both muscle and connective tissue together that support all of your organs. In terms of the ligaments and the connective tissue side of things, sometimes there can be injury. So for example, trauma during birth and delivery, but it's the muscle that we want to focus on in terms of strengthening, because that's what we can change, especially post-delivery. So this is my attempt at being tech savvy, so bear with me. So you can kind of see here, if I just pause it, we've just got the skeletal sort of system here with your pelvis. So you've got your pubic bone at the front, you've got your tailbone with that triangle, and we're going to turn around and we'll see the back as well. And if we pause here, we can see our sacroiliac joints on either side. So this is the pelvis that kind of makes that bowl that we talk about. And then if we kind of look underneath, we can start to see the muscles appear in a second. That's me readjusting. Oh, probably went too far there. Let's come back. So you can kind of see here, there's a deeper layer of the pelvic floor, and it looks like a ring. You can see it wraps around like a U shape. And then we've got the superficial layer on the outside as well. So both of these layers work together, and we're going to go through that when it comes to strengthening those muscles. So I like to use this picture as a guide when I teach my clients how to activate their pelvic floor, because it's actually kind of a cross section. So if you imagine we cut you down the midline of your body, we've got your pubic bone here, we've got your tailbone here, and we can now see that sling a little bit clearer, this red musculature here, and this is the anus. So in terms of the organs that we mentioned, the pelvic organs that we want to support, we've got your bladder here, we've got your uterus where bub grows, and then we've got the rectum at the back. So in terms of cues, this is when I'd like you to kind of, I guess, talk about what you might have tried or what you might have heard from friends or even from a GP. What cues work for you in terms of sort of activating the pelvic floor? Tracy, what would you normally cue for people?
I think it's more just being able to identify those muscles. So I think knowing where they are and how to find them. So I usually tell people it's like if you're going to the toilet or you're bearing down, you're pushing down, like you're trying to let your bladder go. And then if you were to try and stop yourself from peeing, what do you have to do? And usually to do that, we find if you're sitting there and thinking about it, you end up drawing or squeezing the vagina and sort of pulling it upwards.
Yes.
And at the same time, it also tightens the muscles around the bottom as well. So once we've found those muscles, then I can instruct people on how to relax or contract those muscles. Just being aware of being able to use them in the first place. So it is that very much that squeeze and lifting, that sort of drawing inwards.
Yes. And it's not like a bicep curl where you can kind of see your arm move. That's what makes this muscle really hard to exercise in the first place. So cues I do find can be quite helpful. We're going to come back to this slide in a second, but like you mentioned, one cue is definitely imagine you're midstream on the toilet and you want to stop the flow. In particular, if I have clients that can't actually activate or just don't have the awareness of their pelvic floor just yet, I actually allow them for 1 week, try once a day on the toilet to stop the flow and then let it go again. And it's really important to be able to let the flow start again, because sometimes you'll be able to stop it, but then you realize you're actually at the end of that urination. So you realize you haven't relaxed the pelvic floor either. So you stopping the flow of your pelvic floor, of your stream, is your pelvic floor switching on. And then as long as you can relax and let that flow start, we know you have the ability to relax your pelvic floor as well. Another one is tummy full of gas. You don't want to let it out. So focusing a bit more on the back passage there. Also, if you imagine that you've got a tampon and you want to hold it in, that's that sort of squeeze and lifting sensation. And my favorite, which I've learned, is imagine, so if you see this photo here, imagine you've got a puddle and you're dropping a little pebble into the puddle. So when you drop the pebble, the waters will ripple out. So that's your pelvic floor, just relaxing and letting everything drop. But then if you imagine that sort of image in reverse, so those ripples come back in and your pebble comes back up, that's your pelvic floor switching on. So for those who are sort of visual learners, that one actually works quite well. Have you tried any others, Tracy, or even anyone here? Have they got any tips on how to work their pelvic floor, anything they've heard in the past? All right, well, let's work on how long and how many times do we need to do this, because it's always a question that I get. So we might actually try it together. In general, our goal is endurance in terms of being able to hold your pelvic floor for 10 seconds, and we aim for 10 reps once a day. So everyone's going to have their own sort of baseline starting position depending on how strong their pelvic floor is. So that's what we would work on together, and just figuring out how many times can you hold it, how many seconds can you hold it, and that's sort of what we send you home with, and we start to build up towards that goal as able. But we might try it together because it's a nice one to kind of figure out while we're here. So I want everyone to sit upright with their feet flat on the floor. So posture will make a difference. It's actually a lot harder to activate your pelvic floor when you're sort of in a slouched position. So we're going to stay upright. And I find that sitting is quite nice because you almost get a feeling of your pelvic floor lifting away from the chair underneath you. So for those who realize they can get that feedback from their pelvic floor, that's actually quite nice for a lot of people. So one thing that a lot of people will do is hold their breath. So we're going to count out loud together, because that way at least you know you're breathing. But the main way people will cheat is they'll brace through their belly or they'll clench through their bottom. Like you mentioned, Tracy, they'll kind of use other muscle groups to assist them. So I want you to pop your hand underneath your bum and just make sure it feels nice and soft underneath there. So we're nice and tall. We're going to count out loud. I want everyone to imagine that pebble. We're going to squeeze and lift. Hold 1, 2, 3, and relax. So it's just as important to feel that relaxing sensation as well as that squeeze and lift. We're going to try again. Squeeze and lift. 1, 2, 3, and relax. So even if you're on mute, I'd like you to count out loud. Here we go. Squeeze and lift. 1, 2, 3, and relax. So for some people, 3 might be challenging enough, and you felt sort of 2 seconds and that kind of could feel that quiver and it just started to drop. And for some people, 3 seconds might be fine. So you'd want to work more towards 5 seconds or even 7 seconds. So you want to see how many times can you do that. Just like going to the gym, you want to strengthen the muscle by pushing it to fatigue. And the pelvic floor is just like any other muscle group. So you actually want to feel like by the end of your sets, that pelvic floor is tired, it's done its work. Okay. So I think the main thing is if I have a client, for example, who has symptoms and has incontinence of some sort, I would generally tell them to do their exercises before bed, because at least that way they can kind of relax overnight, the muscle recovers, and then they're good to go for the next day. Because I do find that sometimes if you do this exercise first thing in the morning, you got to think you're sort of walking around with a relatively tired pelvic floor, and that can sometimes increase symptoms as well. Any questions about that before we move on? Does that sort of make sense?
I think the good thing about the pelvic floor, like you said, it's not like watching someone do a biceps contraction. So you can sit there quietly and do exercises, like even if you're in the waiting room.
No one needs to know.
And no one would even know.
Yeah. You just see this concentration on people's face though, so that can give it away. But other than that, it's generally all right. Alrighty, so moving on. So I guess the main thing we want to bring up today is just sort of common pain or niggles that can pop up, or even conditions relatively common during pregnancy. So if any of these apply to you personally, again, feel free to unmute and ask some specific questions. I'm more than happy to do that. So first up is lower back pain. Is there anyone in the room that has lower back pain currently during their pregnancy? All right, well, a question that I normally get is, especially if they're trying to get pregnant and they're worried about, say, if they already have lower back pain, the general consensus is that generally their pain will either stay the same or it will get better due to the laxity of your ligaments. Is that what you find, Tracy, with your clients?
Mm.
Yeah. So I think a lot of people are generally concerned because they think, oh gosh, I've got back pain now. Is it going to get worse? And how am I going to tolerate this pregnancy? So in general, it does actually feel better during pregnancy if you've had a history of lower back pain. But lower back pain is generally any pain in that sort of lower back area. It can radiate into the bottom and even down the leg. They're normally aggravated just with bending, twisting, lifting, especially if you are pregnant but you also have another child. You might be lifting Bob, picking things up the floor. That will tend to aggravate your pain. And it can actually be the position of the baby. Do you see much of this, Tracy, in terms of the presentation of the baby?
Yeah, so depending on which way the baby's facing, sometimes you can actually produce more pressure on the back or the pelvis. But generally what's common is common. So most of the time baby's facing the right way.
Okay, yeah, good to know. And then the next most common pain is pelvic girdle pain. So you can kind of remember from the little video that I tried to make earlier, we've got that pubic bone at the front, pubic symphysis. So that's a common site of pain during pregnancy. We can get tailbone pain at that coccyx area, and generally one side, but can be bilateral, is that sacroiliac pain. Gosh, okay. So in terms of a little bit more detail, generally, if you haven't had this pain previously and you start experiencing some kind of pelvic girdle pain during pregnancy, unfortunately, it does tend to get worse. So sometimes with physio management, it's actually more about just plateauing your levels of pain, managing your pain rather than trying to fix it. Because I do find that generally within about 3 months post-delivery, that pain does tend to subside on its own. But this kind of pain is generally a little bit lower than your lower back pain. So it's more in the bottom area, can go down to the back of the thigh, but generally not as far down to the leg. You'll normally find things that aggravate it is sort of asymmetrical movements. Anytime you're standing on one leg, for example, putting on shoes, stairs where you have to balance on one leg as you go up and down on the other leg. Walking can also be sore, getting in and out of the car, getting in and out of the bed. Those are the typical sort of signs that I saw with that. Do you find anything else aggravates pelvic girdle pain, Tracy? Those are the typical ones.
Yeah, I think the rolling in bed is one of the big ones. So
Mm.
one of the ways around it is to actually keep your legs together when you're actually trying to get in and out of bed, as opposed to letting the knees come apart, or even putting a pillow between your legs when you sleep. Obviously, once you're in the second trimester, we're trying to avoid sleeping on the right-hand side, which is sleep on the left or on your back. But I think keeping those knees together helps when you're getting in and out of bed. Mm-hmm.
Yeah, definitely. And so I guess in terms of the reason why, there is just the hormone changes during pregnancy, unfortunately, which increases the laxity of your ligaments. So because of that laxity, that can increase the amount of effort that your muscles have to then support your joints, which then can just either lead to muscles getting super tight or just overworking, and that can create pain, or even just within the joint itself, that can be the source of your pain. So like Tracy mentioned, there are different sort of cues or advice that we can give you in terms of managing your pain. So trying to keep your knees and feet as close together throughout movements. So getting out of bed and getting out of the car, sort of swinging your legs through, as awkward as it looks, is going to be a little bit better in terms of pain. And even just walking with smaller steps means that your legs aren't quite as far apart when you are walking, and that can help. I found that pelvic belts work really well just in terms of managing pain. So it just provides a little bit of compression and support around the pelvis to add to what your muscles are probably trying to do during pregnancy. And then as you get bigger, it obviously becomes a little bit harder. So that can be a way to manage your pain moving forward through the trimesters. Manual therapy does work in terms of just trying to release tight muscles. But again, it's just a band-aid fix until we can sort of get you out of that pregnancy and stronger postnatally.
Mm-hmm. The other thing that sometimes can help is when you're coughing and sneezing, especially when you're getting a bit bigger, is to actually just lean forward a little bit and kind of put your hand under your bump and kind of brace yourself a little bit when you're coughing and sneezing, because it's just that transmission of that force through the abdomen into the pelvis can kind of just give you a little bit.
Yeah, that's true. So, good point. Definitely.
And the idea is just to keep moving, but obviously, so keeping active is important, but obviously doing smaller movements, and so breaking up the vacuuming, breaking up hanging out the washing, that kind of thing, into
pacing yourself makes a big difference.
Bite-sized things that you can manage.
Yeah, definitely, because then you at least give your muscles a bit of a break in between that activity, and it still accumulates the same amount of exercise, but there's a bit of a rest in between.
Correct.
Okay, great. So diastasis rectus abdominis. So this is something that happens very commonly in pregnancy. It can be quite concerning for a lot of people, but it's actually very normal, and it's good to know that it's a normal thing that happens. So essentially, you can see sort of from this picture here, everyone has a six-pack muscle, even if it's hidden underneath. But you got your right half, your left half, and we've got what we call linear alba, which is connective tissue smack bang in the middle where your belly button is. So as bub grows, it's absolutely normal for there to be a natural amount of separation through those two halves to accommodate for bub growing. And so generally, it's just something that we monitor during pregnancy as a physio, because really by 35 weeks, on average, as 100% of women will have some kind of separation. So I think it's good to know that it is normal, and the main thing is that we can kind of work around it and modify things like exercise depending on whether you have a separation or not. So generally, we're looking at about 1 to 2 centimeters for your average pregnancy, potentially 3 centimeters if you've got a heavier baby, and more towards 4 to 5 centimeters if you have twins. Does that sound about right to you, Tracy?
Yeah. Yeah.
So it can be quite big. And again, it's completely normal. And in terms of physio and rehabilitation, we're actually looking to make most of the change within the first 2 months postnatally. So after delivery, things like an abdominal compression stocking can help just sort of support everything post-delivery. While you're sort of, you've got those hormones running through your body within the first 2 months, that's when that connective tissue that I mentioned earlier is actually quite soft. So that's when you're going to make the biggest difference to that separation. Sometimes after that linear alba starts to harden, it does become a little bit harder to create that sort of gap closing that we want. But in terms of strength, no matter how far that separation is, like I've had clients with a 4 centimeter, 5 centimeter separation, but with incredible abdominal strength. So strength can actually always sort of return. It's just that separation sometimes that we have to deal with, unfortunately, especially if this is, for example, your 3rd pregnancy or 4th pregnancy and you never really did anything about it earlier. Sometimes you're starting your next pregnancy with a separation already, And then we're obviously going to have a little bit more of a separation throughout that next pregnancy. So it is something that's probably good to be aware of now, especially if you're planning on having more kids in the future. It might be something that you want to get back together before you go into your next pregnancy. All right. So the main thing is there aren't really too many studies on the tummy muscle separation, unfortunately. So the main risk is just heavy lifting during pregnancy. So you want to make sure you avoid anything that's going to cause too much abdominal strain. But then what we want to look out for is what we call doming. So this is kind of, you can see if you're imagining the right half and the left half and that separation through here, anything where there's too much load through abdominal muscles, you'll actually notice what we call doming or coning, where there's a bump that appears right down the middle of your belly. So anytime you notice this, we want to make sure that we can modify that movement. So that, for that reason, we generally avoid obviously crunches and planks, anything too high load through the abdominal muscles. But even sometimes simple things like getting out of bed can cause this doming. So we teach the log roll, turn yourself onto your side, swing your legs over and use your arms to help you up. So little things like that can make a difference just on the load through your tummy. Is there any other things you want to add to that, Tracy?
I think the main thing is not to hold your breath sort of when you're so if you're bearing down, so for example coughing or sneezing, so that those kinds of things, or pushing on the toilet, for example, trying, if you're constipated, these kinds of things, or picking up something heavy, they put a lot of pressure through the abdomen, and basically you've just got to make sure you're actually breathing and not sort of straining when you're doing those things, so to try to distribute that
especially when it comes to exercise. So for example, if you're still doing strength training and exercise, chances are if you're holding your breath, you're going to start to strain too much.
Pushing. Correct.
Yes, exertion. You want to breathe out, like everything relax. All right, great. So another common presentation is carpal tunnel syndrome. So basically there's a nerve that runs through the wrist and you can get compression through that. Basically because of pregnancy, you can get some fluid retention and it's generally lower limb first, so in the legs, but it can be in the upper body. So any kind of increased fluid around that area can tend to cause a bit of compression of that nerve. So the symptoms can be pain in the fingers and hand. There can be tingling or numbness and sometimes a weakness in the grip strength. How would you normally treat this, Tracy, if you were to see this in the clinic?
So the first thing is just to make sure that's what it is. So with the carpal tunnel, basically there's a thick connective band tissue here, and it goes across the wrist, and there's a number of structures that go under that connective tissue band, and one of them is that nerve, and the nerve's called the median nerve. So it comes up right in the middle, and it generally supplies the sensation to these three fingers. So often we'll find that tingling occurs. It's actually, it tends to be worse at night, so often you wake up in the middle of the night, you need to shake your hand, but it can be throughout the day. And it'll be worse when you actually cock or flex the wrist. So if you're doing things and the wrist is bent, or you're doing things and the wrist is extended, obviously that's going to stretch the nerve and that's going to squash the nerve. So either those types of things will often aggravate it. So if we're confident that's what it is, then the treatment's usually conservative, meaning often it gets better once your pregnancy resolves.
Yeah, definitely.
And your hormone levels adjust and your fluid balance goes back to normal. But it can be really annoying. So it can be burning and you can have that weakness. So splinting, you can get a customized hand splint. You can buy commercial ones, but I find customized ones that are made out of thermoplastic, lighter, more tailored to you, easy to remove on and off because they've got Velcro, so they can be really helpful. Absolute worst case scenarios, we can inject with cortisone, and that's not particularly harmful for baby because we're putting the injection right in the wrist, but we try and avoid that unless we really have to. And then if these symptoms happen to persist in the future, like I said, they almost always go away, but if it just so happens that we're a little bit an older woman and we've had a few kids and it doesn't seem to be going away, then we might think about actually doing surgical release, which is very quick. It's a day procedure. So you just release that thick band of tissue and then give that nerve breathing space, and then the symptoms are resolve.
That's good. All right, you can see how tech savvy I am. I'm trying to get out of this.
Oh, you're all right.
How do I get back to...
You can always hit exit and see if that just...
Yeah, there's just no exit on here. Hold on.
Or just hit exit on your keyboard, that might help.
Right.
And I'm terrible because I don't have a Mac, so
yeah,
anything of it, I'm like, oh yeah. I'm just, Samsung, PC, I don't know.
I apologize.
And we can make do if we need to because your text is pretty big, so we can make do if we need to read the slides on small print.
There we go, we're back.
Fantastic.
Very sorry. Alrighty, so another thing I'd like you to talk about, Tracy, if you can, is just diabetes in pregnancy, because we deal with a lot of clients in terms of exercise rehab and how we can manage that on our end. But what do you have to say about that?
Yeah, so diabetes, most people sort of know a little bit about diabetes. So essentially, whenever we eat food, it gets broken down, and then your guts absorb it, and then your sugar levels in your blood go up because it gets absorbed from the digestive tract. And then we've got a gland called the pancreas that kind of sits just below the stomach and behind it, and its only one of its jobs in life is to release insulin, which is a hormone. So insulin basically reduces your blood sugar level. It pushes or it tells the cells in your body to take up the sugar, and it lowers the blood sugar. So the reason that we can be at increased risk of developing diabetes in pregnancy is because of the hormones going around and the placenta as well. But essentially what happens is the hormones make the cells in the body less responsive to insulin. And as a result, we can end up with higher blood sugars. So the reason this is a problem is that having chronically high sugar around can increase our risk of having a preterm labour or making baby larger. So it's called macrosomia, and meaning that baby's more likely to get stuck if we're having a normal vaginal delivery.
Yeah.
If we have really high sugar, the other thing is that bub gets used to that. So as soon as bub's born, they can have really low sugars and sometimes need to be looked after in the nursery or have actual sugar top-ups. So there's some of the potential problems. Sahanna's put some risk factors there, but basically our risk of gestational diabetes goes up the older we are, and there's actually for every year over the age of 18 years of age,
really?
There's a slight percentage increase.
Right.
But that becomes a little bit more significant when we get to 35. So definitely 40 is a risk factor.
Yeah.
If you've had diabetes, a family history of diabetes, or if you had a previous pregnancy with gestational diabetes, and obviously you're at increased risk as well. Increased body mass, probably over 25, definitely over 29, but above 25, this is an increased risk as well. And obesity. So the heavier you are to start with before your pregnancy, and your activity levels definitely increase your risk as well. So it's routine in your 24 weeks to do a glucose tolerance test, which everybody complains about. So it's not very fun. You go and get a blood test. You have to drink 75 grams of liquid, sugar.
Apparently it tastes terrible.
Sugar. Yes, it doesn't taste very good. Then you get another blood test in an hour. And then guess what? You get another blood test at 2 hours. And they generally don't let you leave the room because you can't go off and go to the shops or anything in between. You kind of have to sit down and make sure you're not really using up all that fuel. And we basically measure the blood level and we decide whether your body's actually managing that sugar load or not. And there's different cutoffs, but the Royal Australian and New Zealand College of Obstetricians and Gynecologists, they've sort of set the cutoff at about 8.5 as of last year. So, but there's different guidelines, but essentially a doctor will tell you whether you meet that criteria for diabetes. The good news is that if we diagnose gestational diabetes in pregnancy, the management is almost always just monitoring your sugars and modifying your diet. So you basically have to eat like a diabetic, which is reducing the amount of sugar you eat and trying to substitute your carbs for what we call lower glycemic index or lower GI carbs. So these are foods that are starchy but last longer and don't break down into sugar as quickly. So for example, potato is very starchy and it's got a higher glycemic index than something like sweet potato. So sweet potato is a better choice, in other words. And you might substitute your brown bread for instead of white bread. Generally, rice and pasta are good sources of carbohydrates as well. So you're trying to get rid of your sugars, basically your sugary drinks and your sugary snacks. And so that's sort of the management. The good news is generally delivering baby, because I explained that normally the hormones are a cause of this. Often your sugars will go back to normal after the pregnancy.
Yeah.
Having said that, 50% of women who have gestational diabetes may go on to develop diabetes in the future. So it is something that's important to look for during pregnancy and manage well.
Yeah. And if, just say, for example, a woman had gestational diabetes during their first pregnancy, is that something they could stay on top of to prevent a recurrence in their second pregnancy?
They've got an increased risk in their second pregnancy. So we still occasionally speak to your doctor and see if you want to do the test earlier, but 24 weeks is generally when we do
I see.
the test.
Yeah.
But look, in the next few years, things may change. We may not need to do that glucose tolerance test anymore. So there's been a shift in overseas in America and the UK in terms of doing another test called a HbA1c. So this is a blood test where you don't have to drink the sugar load.
Oh, there you go.
But we usually use that to monitor diabetes rather than diagnose it. So it's still not, we still have to do this annoying sugar test, but given the other things that we have to go through with pregnancy, I think it's not too much to ask.
Alrighty. So I think, like you mentioned, there's management that we need to look at. So from the sort of physio perspective, you mentioned diet, but we want to look at exercise and just trying to keep you fit during your pregnancy to monitor your symptoms and keep you on top of that. So next topic is exercise in pregnancy. So in terms of guidelines, you can sort of specify a little bit more, Tracy, but I generally kind of want my clients to be exercising, if not every day, most days of the week, and aiming for about 150 to 300 minutes a week of exercise. I generally use the talk test in terms of intensity, so you should still be able to carry a comfortable conversation while you're exercising, so never overexerting yourself to the point where you can't talk to someone. And as a general rule, we try and avoid exercising on your back after that first trimester. So we'll go on to the next slide. I think, Trace, if you want to talk a little bit more about the Borg scale.
Apologies if this is really fuzzy to read, but the Borg RPE scale, so this is just a rating scale. It's not specific to pregnancy. This is in terms of exercise exertion in general. So we just rate, your effort basically, and it's a scale of 1 to 20. But generally in pregnancy, we're trying to aim for a moderate intensity exercise. So according to this scale, 12 to 16, and you can kind of see it's rated as somewhat hard. So it's so you sort of be a little bit breathless, but like Sahanna said, having that talk test, you can actually still talk to someone, obviously in shorter sentences. So we're trying to avoid exercising that really, really hard category. The other way to measure this, we can go on to the next slide, is just giving people some guidelines about heart rates as well. And obviously this is going to differ a little bit depending on people's fitness. But this information comes from Sports Medicine Australia, and they have some pregnancy guidelines and position statements. But this information is also supported by the obstetric colleges of Australia and New Zealand as well. So generally speaking, somewhere for someone who's not pregnant, we sort of say the upper limit of your heart rate when you're exercising should be 200 minus your age. Whereas in pregnancy, it's something more like 180 minus your age. So if you kind of have a look, for example, disclosing my age, but I'm in that 30 to 39 category. Okay. I'm actually 38 and a half, so I'm just
there you
go. But so the maximum heart rate per minute I'd be wanting to exercise is 140, 145, and that's just to make sure that that blood flow through the placenta to baby is not restricted. Because obviously we're sharing, you are sharing.
Sharing the load.
Yeah, in terms of what type of exercise, so there's two types of exercise we recommend in pregnancy. So one is that aerobic exercise, which is the continuous sort of low, constant sort of intensity. So that's walking, swimming, cycling. In terms of running, we never say to someone you're not allowed to run in pregnancy. If you were previously a runner and you ran quite a fair amount, and that's something that you generally can continue to do in pregnancy unless there's certain reasons why not. But you know, the problem is that your center of gravity changes as you move through your pregnancy. In other words, the bump gets bigger, and your center of gravity isn't really in the center of your body anymore. It starts to shift forward, and your balance sort of changes. And also the progesterone, estrogen released by the placenta, as well as other hormones like relaxin, they soften your ligaments and they soften your joints, which means you're a little bit more likely to, you know, roll your ankle or
injury risk
stretch or injure something. Yeah. So for that reason, we generally try and tell people not to do activities that change a lot of directions. For example, you know, not probably playing netball as you move into the second trimester. And you're trying to jog or move in a straight line as opposed to changing direction. Things like yoga, Pilates, so basically staying on the ground in a controlled way is very useful. And we obviously don't want to be doing things that are going to be putting you at risk of falling or getting knocked or kicked or punched. So generally speaking, we also tell people to stop doing their, you know, boxing or martial arts if someone's actually coming at them, or horse riding. We do tell people that skiing is not recommended, although that makes people very sad. Okay.
Oh gosh.
Yeah.
Yeah. So I guess in terms of physio and what we would really want to focus on during your pregnancy is specific strength. So legs, you'll be surprised how many times you're going to squat once you have a baby. So you want to make sure you've got enough strength through your legs, arms, just because you're going to be carrying Bub, and Bub is heavy. I remember I took a Pilates class and it was a 6-week-old baby, and I offered to carry the baby while I was taking the class, and so it slept in my arms for 45 minutes. The second I handed the baby back, I'm like, oh my God, my biceps. So prepare yourself for some arm strength. Just in terms of posture, especially during your pregnancy, and again afterwards when you're breastfeeding, but obviously your breasts are going to get bigger during your pregnancy, and that's going to pull you into that forward slouch posture. So if we can work against that during your pregnancy, then you're going to better your outcome in terms of pain and postural dysfunction postnatally. Gentle abdominal loading. So it is safe to still engage in your abs during your pregnancy, but like I mentioned earlier, just making sure that it's never to the point where you're getting any kind of doming or coning through your abdominal muscles. And number one is your pelvic floor. So making sure you have the activation and awareness of your pelvic floor, and that we're working towards that 10 seconds, 10 reps with your pelvic floor, because the stronger you get your pelvic floor now, especially if you're having a natural delivery, but regardless, the better your outcome is postnatally afterwards. All right, so again, sort of in terms of medical clearance, Trace might chat about when it might be unsafe to exercise. Mm-hmm. So in terms of gestational diabetes, we want to look at your blood sugar levels.
Yeah, so there's a few conditions. So with blood sugars, generally we monitor them, or if you've been diagnosed with gestational diabetes, you'll be asked to monitor your blood sugar. So you do that by pricking the finger and then putting a drop of blood onto a machine that will give you a reading. So generally we want that level to be not too low in the morning or during the day. So below 6 is lower, but below 4 is considered very low. But often we don't really want to be relying on the numbers. We kind of need to be paying attention to what our body's doing as well. So often your body will give you cues when your sugar level's low. And the list of symptoms here are some of the things you might notice. By the time you feel confused, I would suggest that we probably wouldn't be waiting or relying on that. Earlier symptoms are feeling dizzy, shaky, a bit lightheaded, feeling really hungry, because your body actually is pretty good at telling you when it needs and then feeling a little bit clammy or sweaty. Weakness is just feeling tired or floppy. But these kinds of symptoms, if you're suddenly noticing that, we probably wouldn't encourage you to exercise. And if you have diabetes, obviously to check it. I think it's really important in pregnancy to make sure that you are eating at regular intervals. So we're trying to avoid fasting, and especially for people who are still working or shift work, you've got to just make sure that you are having your breaks and you are eating on a regular basis. So here, obviously, if you're feeling really dizzy and very low with your sugar levels, you might try and increase it by having a couple of barley sugars or 100 mils of lemonade. But we would always follow that up with a carb or something to eat that's actually going to last a bit longer. We don't want a sudden surge in the sugar. So you probably eat like a starchy biscuit or half a piece of bread as well afterwards, if you can get your hands on it. So some of the other conditions that we would be a bit careful with exercising is if you've got significant heart or lung problems, like a hole in your heart or irregular heart rhythm. You'd obviously discuss with your doctor how hard to push with your exercise and how much to do. It's not that you can't. There are a few other things as well. So there's if you've got obvious bleeding from the vagina or clear fluid loss, which we're not sure if your waters have broken, then you obviously would stop and figure out what's going on there. Generally, if you've got cramps or pains, and they don't have to be severe, that's sort of unexplained. So, and this is more in the second and third trimester. So if it's in the lower back, your pelvis or your abdomen, we just want to double check that you're not actually having early contractions. It's more likely to be something else. So it's more likely to be pelvic girdle pain or round ligament pain. But if we're unsure, then you always run it by your GP or obstetrician. Other things that would be a reason to be careful with exercising is if your cervix is incompetent. So this is your cervix basically is at the bottom of the vagina and it stays closed. And in some women, it can become wider and shorter a little bit too early in the pregnancy. So normally it only shortens and widens right at the end when you're during labour, okay, to let baby come out. But in some women in the second trimester, it can start to get a bit shorter earlier. And this increases our risk of having an early preterm delivery, which obviously we don't want. So the good news is that this is routinely looked for on your 18 to 20 week scan with an ultrasound. And if it looks like the cervix is shorter than 35 millimeters, which is the cutoff that we've been given by the college, then you can go on to do a vaginal ultrasound. So what that means is putting the probe inside the vagina and having a better look at the cervix. And this is safe for baby, but it's more accurate measurement. And if that measurement continues to be low or it's less than 25 millimeters, then generally it's not safe to do significant impact exercise. And also we need to try and stop the cervix from continuing to shorten. So the treatment for that is to use progesterone, which is a hormone, and so it comes as a pessary. So you put it inside the vagina and you do that every night, probably until delivery, until 37 weeks. The other way of treating this is to put a stitch. So you can actually, it's a medical procedure where you put a suture or a stitch into the cervix just to make sure that it doesn't loosen. So if you have that condition, then we need to protect that. There might be a couple of other things as well. If you've got decreased fetal movements, then we'd want to check that and not be exercising as well. Or if you've got symptoms to suggest that you might have a blood clot, which is sudden swelling in your calf or sudden shortness of breath. Another thing that you want to be careful about is symptoms of preeclampsia. So if you've got sudden swelling in your feet or your hands or in your face, and we expect a little bit of swelling, but gradually with pregnancy. So if it's sudden onset of swelling, then we would also suggest that you stop exercising and check with your doctor first. So there's some of the things to watch out for. Mm-hmm.
Great. So we've just got some resources here from Tracy that might be helpful for you. And we'll make sure we send out these slides because there's some information here which we might have kind of bypassed, but at least you can have a further read on later. But we'd like to take the chance now if anyone has any questions.
Sophia looks like she's trying to unmute. There you are.
Yeah, there we go. Hi, Sophia. How are you?
Good, thank you. I just had a question about core exercises. So I know after 12 weeks you have to avoid supine exercises. What sort of modifications would you suggest? I can think of maybe 3, but yeah, I'm kind of...
I mean, I do a lot of rehabilitation with Pilates. So the benefit of even being on a moving carriage in the kneeling position challenges your abdominal muscles to an extent without having to strain through your abs. And to be fair, your abs are still going to work with a lot of other exercises without having to do a crunch or a plank. So I don't normally push it with the abdominal muscles during a pregnancy class, and I'd much rather focus on that postnatally.
Yeah, I'm also a Pilates instructor, so I'm a
great
Pilates instructor. So would you do things like, I don't know if you do wood chopper or oblique twists or things like that?
Yeah, so I would probably avoid those because of the strain through the abdominal muscles. And yeah, I wouldn't put too much load with that.
All right, brilliant.
Yeah.
I think doing some of your exercises upright, like sitting on a ball, for example, and you'll be engaging your core the whole time.
Just to balance on the ball. Yeah,
balancing. So just incorporating a lot more balance into all your activities. I think will actually help you contract those core muscles. And I think the target is you're not going to be trying to build abs during your pregnancy, but you're going to try to maintain that strength. So I also wouldn't advise doing wood chops. I think the motion itself is fine, but once you start adding load,
so for a rotation stretch, that's fine, but I wouldn't add the resistance.
All right, cool. I remember that. Thank you.
Nice. Any other questions?
Yeah, I've got a question.
Hi.
Thanks for all that information. It was really good. I guess I'm in my second trimester now. In my first trimester, I basically was on the couch for most of it, and I feel like I've lost quite a bit of strength through not being so sick for so long. And I'm just at the point now where I'm feeling well enough to think, okay, let's start doing some strength exercises again. I've still been walking a lot, which is nice. So, and I was just wondering, like, they say sometimes you have to avoid, because you're, I don't know the right terms, but everything becomes more stretchy. So, you have to start avoiding some things like lunges and maybe some types of squats as well. You were talking about, being careful the way you maybe twist and move your body. But are squats still safe? And which way should we be doing them, or how can we strengthen our legs as well?
Yeah, so I personally use squats all the time. I think it's a great exercise to get your glutes stronger. I think it's more about the load. So I wouldn't necessarily have a 20-kilo bar on your back while you do the squat, but squats are absolutely fine. And to be fair, you do it during the day without even thinking it's a squat. So there's no reason why you shouldn't be doing that. Yeah. The only reason I would modify a lunge is if they have that, what we were talking about, that sort of asymmetrical pelvic pain. And if that was an issue with the lunge, then I might try and find an alternative exercise. But if pain wasn't an issue, then again, a lunge would be okay for me. But again, just watching that weight and just making sure they're able to engage in their pelvic floor during the exercise.
Okay.
And I think, Anya, it's a lot about common sense. So you'd start low and slow. So with your squats and lunges, I think you're just avoiding looking at your depth. So with your squats, you might be doing body weight, mini squats to 45 degrees, 60 degrees, to start with, and just building up, or even just doing wall sits to start off with, so just firing up the quads again and building that sort of static strength first before you progress into to active exercises.
One that I love is a door frame squat. So you actually hold on to a door frame with your feet sort of straddling the door frame, and you can actually use your arms to assist the squat. So that can be a nice way to start if you find just a squat on its own challenging.
Yeah, and then the movement's controlled the whole time, and then you're not at risk of the last couple of repetitions being a little bit too hard.
Yeah.
Yeah, that sounds good.
But I think, pregnancy is not an illness or a disease. We don't have to be wrapped up in cotton wool. And I think the reality is just about keeping things really smart and safe and being aware that your body is changing. So, and having that confidence to be able to exercise. So walking daily is fantastic. So,
yeah.
I have two questions, and they're more about sleeping position. You mentioned earlier that it's not recommended to sleep on the right side during the third trimester. So I was just wondering why that is, and also whether you would recommend a full body pillow. I know you talked about putting a small pillow between the legs, and I found that really helpful with a lot of my clients. But there's also a lot of body pillows out there. So I was just wondering what your thoughts and recommendations are with that.
Yeah, so the way the major blood vessels are organised in our body is that there's a structure called the inferior venous cava. So basically, it's all the veins in your body. Your heart pumps the blood through your arteries to all the ends of your body, so to your head, your fingers, your toes, and that blood comes back to the lungs and the heart via the venous system, via your veins. So the veins bring the blood back to the center of your body, and all of those veins come up the legs, up through the pelvis, and convene into this big structure called the inferior vena cava, and then that feeds back up into the lung and the heart. So the way that works is that it's not the IVC can be compressed by weight. It's not rigid and robust like the arteries are, and for that reason you can kind of squash veins really easily. You see them on the back of your hand. So if we are, as we're moving into the second trimester or halfway through the second trimester, obviously the weight of baby and the placenta is actually significant. So if we roll on and lie on that right hand side, we just might reduce the blood flow back to baby and impair baby's growth. So we don't want to do that. But lying on the left side doesn't seem to cause these problems. There's been a lot of articles and journal articles about this. And then lying on your back's not as bad, but obviously you don't really want to be doing that for long periods of time. Having said that, it's very difficult for people to, you're trying to tell them not how to sleep. And the reality is when you fall asleep, you roll into
do what it wants.
So I don't want you to be fearful, but we try and intentionally not fall asleep on the right hand side if we can, or we'll put a pillow to block that side if you must. I think body pillows are excellent. So, I have friends who just surround themselves with pillows. Do you really need 3? Yep. There's no room in the bed for hubby anymore, but that's okay. Yeah. And between the legs, like I said, I think that's really helpful. So what are your thoughts about all this, Sahanna?
Yeah, I do find everyone raves about pillows when they see me. So I think that's something definitely to invest in, because you'll appreciate it. I do see a lot of clients with hip pain though for that reason, because they're constantly on their side, and that just means a little bit more pressure through those glutes and that area. So sometimes manual therapy can help with that kind of pain as well.
Mm-hmm. Yeah, so I pretty much only really like sleeping on my right side, and I'm not currently preggy, but there's something that I'm like, I might have to figure this out. Yeah.
And in terms of the body pillows, do you have a go-to pillow or just any?
Actually, no.
Yeah, I don't have a specific brand that I know or recommend. So,
Oh, thank you.
Just on sleep, I'm actually a tummy sleeper. As much as I try to go left, I just up on my tummy. Is that? I just want to make sure that's not doing baby any issues. I'm 24 weeks.
Yeah, so it's not really been shown to be particularly dangerous, but I think as you get bigger and heavier, I think the practicalities it's going to be more difficult, but it's not generally recommended. So yeah, it's like I said, I think the only position that's we would not advise is lying on that right hand side.
Mm-hmm. It must be hard for tummy sleepers. Yeah,
you have to sleep somehow, otherwise you're like, you have to sleep standing up, like yeah, but we don't want you to go to bed fearful that you're going to roll in the middle of the night and like I said, so
yeah,
you don't need to strap yourself into bed.
Yeah.
The other question you mentioned about horse riding, and I'm not horse riding at the moment. I'm a horse rider, but I'm not riding. The reason for that, is that just because of loss of balance?
It's just more the risk of falling off, really. So it's the same with bike riding. So at the end of the day, I just give my patients advice. So I'm like, you're always at risk of falling off a horse or a bike, right? And I guess the only additional factor with the horse is that there's another, brain involved.
Living being, yeah.
Brain, but essentially we're not going to be advising pregnant women to be climbing on the doing the gutters for the same reason, or climbing up ladders. So it's just about risk, and at the end of the day it's just advice. So as an individual you're going to make that decision yourself. So obviously we've been horse riding for a very long time. And it's the same with playing contact sports. So there's been lots of position statements from sports colleges, whether, you know, it's safe to continue playing contact sports in that second and third trimester, and how much force is required in terms of impact by falling or knocking to the abdomen to cause, you know, injury to the fetus. So obviously we can't really measure these kinds of things. You can't really do studies on how much force is required before, you know, it's going to cause harm to babies. So we only have anecdotal data. We only have data that's retrospective, meaning that you can only ask people. And the problem with data like that, it's always going to be a little bit skewed. So if you ask someone, you know, something hasn't gone well in the pregnancy, so and you ask them, can you remember, did this happen to you? Then they'll recall that, and there'll be a lot of emphasis placed on that. So, so the reality is, we can only sort of give general, you know, advice and trying to remember that you're looking after two people. But yeah, and I think as you move on to that late second trimester and third trimester, it probably doesn't make sense to continue for other reasons, just because of your back and your pelvis, and the jolting and the jarring may be considered a higher impact activity, so for horse riding specifically.
Yeah, definitely.
Do you ride a lot, Lana?
Yeah, are you pre-baby yet? I'm struggling not riding.
You must be missing it.
Yeah.
I've never actually ridden a horse before.
Oh, really?
Yeah.
Yeah.
I did ride a donkey when I was in prep. I was terrified.
Yeah. Camel's very uncomfortable.
Yeah, I have ridden a camel, actually, yeah.
Yeah.
Alrighty, any last questions?
I had one last clinical.
Yeah.
I'm not sure if this was an anomaly, but in Pilates, I was teaching a pregnant patient, and she would have been, I think it was like 12 or 13 weeks, so quite early on. And she said whenever she was side lying, it didn't matter if it was right or left, she would get cramping down the bottom. So we ended up just modifying it, and I got her upright, and we couldn't really figure out what was going on there. The doctor said all of her vitals were good and didn't really have any recommendations, but could that be a ligamentous strain or, yeah, I'm confused.
Where was the cramping?
So lower down, yeah, sort of just in between the ASIS.
Okay.
Yeah, it might be round ligament.
Yeah, I was going to say.
Yeah. So we didn't talk about round ligament pain, but generally it's, I might just stand up on the camera.
Go on.
Generally pain that kind of is in your groin. Okay. And the round ligament, I don't have a diagram, but the round ligaments are on each side of the uterus, and they kind of hold the uterus up, okay? And it's a ligament that connects, supports the uterus and connects down to the lower part of the pelvis. So the ligament actually goes through the groin or through the inguinal canal and attaches to the labia minora. In other words, the lips, the outer lips of the vagina. And they get slowly and steadily stretched throughout pregnancy. So often this is, you'll notice this pain in the second trimester. It can be earlier, and the pain can be burning, can be sharp, can be jabbing, aching, but generally it's in that groin distribution, and it can be one-sided or both-sided, but often it'll be kind of both-sided. So it's probably similar to what your patient might have been reporting. It's often postural, so you'll find if you're kind of twisting or turning or moving quite
suddenly. I find it's with like a sudden change in movement.
Sudden changes in movement, you'll just get this little sharp pain. So the ligament spasms, it just stretches and spasms and can give you that pain, which can feel like a cramp.
Yeah, exactly, similar sensation.
But as soon as you kind of move out of that position, usually it's okay. So, so part of the management of that is, once again, is, you know, avoiding sudden movements and bracing when you're coughing and sneezing, and keeping your legs together, so that kind of thing. Yeah.
And I find even like a posterior pelvic tilt, so if you were to sort of flatten the tailbone and the lower back, it takes the tension off the round ligaments, and that can sometimes ease the cramp.
Yeah, so you kind of, you know, tilting your pelvis instead
of exactly right.
Yep. You know, so you're trying to do this instead of having that big arch in your back.
So that's something you can do sort of in real time, just to at least alleviate some of the symptoms while you kind of write it out.
And it's not dangerous, and it goes away. So
yeah.
Cool. I remember that. I think it's interesting because I told her to do some pelvic tilts on the Swiss ball, and that helped heaps.
There you go. Great.
Figure it out.
Awesome.
Excellent. Well, it's been really fun, guys.
Yeah, thank you for your time, Tracy. Really appreciate it. And thanks for those who logged on. Hope you found that helpful.
And
if ever you have any other questions at any point in time, feel free to give us a call. I'm more than happy to chat, even just sort of more detail specific questions if you have any.
Excellent. And good luck with all your pregnancies and
yes,
and your work and your patients. So excellent.
All right, it was nice to meet you all. We'll see you soon.
Take care, everyone.
Take care. Bye.
Bye.